Suicide prevention. Suicide is derived from Latin words that mean one's own killing. It is the act of taking one's own life. Most religions forbid this or see suicide as a sin. 90% of the individuals who commit suicide or attempt to commit suicide have a diagnosis of a mental disorder. Throughout history, suicide was considered an offense against the state and is viewed as a selfish criminal act. Individuals who commit suicide are often denied cemetery burials. Their property was confiscated and given to the courts or the crown. The issues of suicide changed during the period of the Renaissance. Intellectuals began to discuss this topic more freely. Philosophers in the 17th and 18th century condemned suicide, but some writers recognized a connection between suicide and melancholy or severe mental disturbance. It was illegal to commit suicide in England in up until 1961, and it has been illegal in Ireland up until 1993. Suicide is on an incline in the US. So I do want to point out that most suicides occur through gunshot wounds, and there's research that's showing that military personnel are at higher risk of committing suicide. In your textbook, you have Table 11-1. It talks about facts versus myths in suicide, and I want you to read them over. So I'm going to go over a few of the facts versus myths. So the person who talks about suicide will not commit suicide. That is a myth. In reality, 8 out of 10 people who kill themselves actually talk about the suicide intentions, or they give some kind of clues or warnings. 2, improvement after depression means the risk for suicide is over. That is false. The risk for suicide increases um, once the person that is depressed starts to feel better and starts to gain energy. So, usually within those first 3 months, they're at a higher risk of suicide. The suicidal threat should be considered attention seeking behavior. That is false. In reality, all suicidal behavior must be approached as a potential act is in mind. Okay? So if someone is stating they may take their life, please take that seriously. Now, I will read the last bullet on this slide, which is suicide is the 10th leading cause of death overall, which is a misperception about suicide. 8 out of 10 individuals who commit suicide give warnings about their intentions. B. Most suicidal individuals are ambivalent about their feelings regarding suicide. C. Most individuals commit suicide by taking an overdose of drugs. D. Initial mood improvement can precipitate suicide. I'll give you a second. And you are correct. The answer is C. It is a misconception that individuals usually commit suicide by taking an overdose of drugs. Gunshot wounds are the leading cause of death among suicide victims. So, risk factors. Single and never married persons are twice likely to commit suicide than someone that's married. Divorce increases your risk for suicide. Women attempt suicide more, but men are more successful with suicide. Women tend to overdose on drugs when men tend to use firearms. And transgender individuals are at a higher risk for suicide with alarming rate of 41%. So with increased age, the risk for suicide increases, particularly among white men over the age of 80. Religious groups, Catholics have a lower rate of suicidal attempts versus Protestants and Jews, but overall, religious groups decrease the risk of suicide. Risk factors continued. So, socioeconomic class, the highest class and the lowest social class are at higher risk than middle class. And for ethnic groups, Caucasians are at the highest risk for suicide, followed by Native Americans, African Americans, Hispanic Americans, and Asian Americans. More than 90% of the people who kill themselves have been diagnosed with a mental disorder. Most commonly, a mood disorder or substance abuse disorder. Individuals who have been hospitalized for a psychiatric illness have 5 to 10 times greater suicide risk than others with a psychiatric illness in the general population. Severe insomnia is also associated with suicidal risks, even in the absence of depression. So, lack of sleep can increase your risk for suicide. In addition, the schizophrenia, personality disorders, and anxiety disorders may also increase your risk for suicide. Suicidal risk continued. So, the use of alcohol, and particularly in combination with barbiturates, increases the risk of suicide. Withdrawal from stimulants increase the risk of suicide when a person begins to crash. Psychosis, command hallucinations. So that is important for you to know. So command hallucinations, they're telling them to do something. So if a patient is saying that they're hearing voices, the voices are telling them to do something, you want to inquire what are the voices telling them to do, right? And find out if they're telling them to harm themselves or harm someone else, right? Command hallucinations. Okay, they pose a higher risk for suicide. Afflictions with a chronic pain or disability may also increase the risk of suicide. So, a family history may increase the risk of suicide, and our LGBT individuals have an increased risk of suicide higher than the heterosexual counterparts. So, I mentioned a few slides previous the 41% of suicidal attempts by our transgender community. About half of the individuals who kill themselves have previously attempted suicide. So, if you have a patient that had multiple attempts of suicide, they're at a higher risk for suicide, and you want to make sure you monitor them closely. Loss of loved ones through death or separation, and a lack of employment or increased financial burden also increases the risk of suicide. In recent years, a number of suicides have been reported in the media among younger people because of bullying. So that's important to know as well. Predisposing factors, theories of suicide. So anger turned inward. Freud believes that this is an act of aggression towards oneself that really is directed towards someone else, usually a loved object. Hopelessness or other symptoms of depression. So there are different depression scales that are used to measure the seriousness of the depression. So the higher the risk or the higher the depression score, the more serious the suicidal thought may be, right? History of aggressive or aggression and violence. So a person that has violent behavior, impulsive acts, are actually less likely to make an attempt of suicide. They may have thoughts of suicide, but they will less likely make an attempt. Shame and humiliation. So, this is the saving face mechanism, some believe. So, to avoid social defeat or sudden loss of status or income, embarrassment, the person may attempt suicide. Theories of suicide continue. Durkheim's three social categories of suicide. Egoistic suicide is in response to the individual who feels separated and apart from mainstream society. Integration is lacking, and the individual feels that they are not a part of a cohesive group. Altruistic suicide is just the opposite, where this person is a part of a religious, cultural, or political group, and their ties are so strong they're willing to sacrifice their life. Anomic suicide occurs in response to changes that occur in the individual's life and disrupts feelings of relatedness to the group. A disruption in its customary norm of behaviors instills a feeling of separateness, fears without being fears of being without support from this cohesive group. Then you have Journer's theory, which is associated with a lack of belonging and increases suicide risk. And we have a three-step theory. And the three steps are pain, connectedness, and so these, with a lack of connectiveness and then pain, psychological pain, increases the risk of suicide. Biological theories. So for genetics, there appears to be a genetic predisposition for suicide behaviors. And neurochemical factors. Studies have shown a deficiency in the central nervous system serotonin levels that are associated with suicide. So the remaining slides talk about the nursing process. I will not read through each bullet. I will read through the subtopics, and I want you to reference your book in reference to each bullet. Table 11-3 does talk about a care plan for a suicidal patient. So our first part of the nursing process is assessment. And for assessment, we have demographics. So I do want to just, these bullets here are the demographics that you need to evaluate in reference to your suicidal patient. And while you're assessing your patient, you want to identify any symptoms that may be present, any psychiatric or medical diagnosis that they may have. You also want to inquire about any previous attempts of suicide or acts of suicide, thoughts of suicide. And if they have thoughts of suicide, do they have a plan? A plan places them at a higher risk of suicide, and any acts or attempts in the past of suicide place them at a higher risk for suicide. They should be monitored closely. Then you have the interpersonal support system. So you want to find out who's their support system, right? And make sure that that is part of your assessment as well. So we just mentioned the interpersonal support system. So analysis of suicidal crisis. So what stressors are precipitating these thoughts or these attempts? Any relevant history? What is the stage of life issues, if possible? um, Psychiatric, medical, and family history. So there was a theory that it does suicide attempts run in the family, genetic related, and as well as neurochemical deficit of serotonin. So it can be medically related. You want to also evaluate how the patient handles stress or crisis situations, and then what is going on in the person's life right now, what currently is causing them um, any types of symptoms that they may have. So in your textbook, it mentions is path warm, and that's an acronym for the present presenting symptoms for your patient with suicide. So please reference your textbook. So your nursing diagnosis, um, risk for suicide related to feelings of hopelessness and depression, hopelessness related to the absence of support system, and precipitation of worthlessness, And I have a third one, ineffective coping related to extreme stress, crisis, feelings of trapped or poor developed coping skills. And our outcome criteria or our goal. So the client goal should always be safety, right? So has no physical harm to self. And the goal should also be realistic, a realistic goal, right? And it should express some optimism and hope for the future. And we have ourselves a question. So the nurse is caring for an actively suicidal client on a psychiatric unit. What is the nurse's priority intervention? A. Discuss strategies for the management of anxiety, anger, and frustration. B. Provide opportunities for increasing the client's self-worth, morale, and control. C. Place client on suicidal precautions with one-on-one observation. D. Explore experiences that affirm self-worth and self-efficacy. I'll give you a minute. And you are correct. The answer is C. Placing the client on suicide precautions with one-on-one observation provides a safe environment for an actively suicidal client. Maintaining client safety should always be a priority nursing intervention. Let's review some guidelines for treating suicide clients on an outpatient basis. So the person should not be left alone. Arrangements must be made for the client to stay with family and friends. If it's not possible, hospitalization should be reconsidered. A no suicide contract may be established with the client, but only as an adjunct to other interventions. The focus of this intervention is to formulate a written or verbal contract that the client will not harm himself or herself in a stated period of time. Enlisting the help of family and friends to ensure that the home environment is safe from dangerous items such as firearms or stockpile drugs. Give support give support person the telephone number for the counselor and emergency contact in the event the counselor is unavailable. Appointments may need to be scheduled daily or every other day at first until the immediate suicide crisis has subsided. Establish rapport and promote a trusting relationship. It is important for the suicide counselor to become a key person in the client's support system at this time. Be direct, talk openly and matter of factly about suicide. Listen actively and encourage the expression of feelings, including anger. Discuss the current crisis situation in the client's life. Use problem solving approach. Help the client identify areas of life situations that are within his or her control and those that the client does not have in the ability to control. Discuss feelings associated with these control issues. The physician or nurse practitioner may prescribe antidepressants for an individual who is experiencing suicidal depression. It is wise to prescribe more than a 3-day supply of medication with no refills. So that's so that they won't attempt suicide with the medication. So we have ourselves a question. A client with a history of suicide attempt has been discharged and is being followed by an outpatient clinic. At this time, which is the most appropriate nursing intervention for this client? A. Provide the client with a safe, structured environment. B. Isolate the client from all stressful situations that may precipitate a suicide attempt. C. Observe the client continuously to prevent self-harm. D. Assist the client to develop more effective coping mechanisms. And the answer is D. Assist the client in developing more effective coping mechanisms is a nursing intervention that can and should be implemented in an outpatient setting. So you always want the patient to develop those coping skills to deal with the stressors or triggers and prevent these future attempts of suicide. So information for family and friends of the suicidal client. So you always want to educate those in their immediate circle, those that are close to them. So take any hint of suicide seriously. Do not keep secrets. Be a good listener. Express feelings of personal worth to the client. Let them know how important they are to you, right? Know about suicidal intervention resources. Restrict access from firearms or other items that may harm themselves. So acknowledge and accept the person's feelings. Provide a sense of hopefulness. Do not leave the client alone. Show love and encouragement. Seek professional help when needed. Remove children from the home. Do not judge or show anger towards the person to provoke guilt in him or her. Interventions with family and friends of the suicide victim. So encourage him or her to talk about the suicide. Discourage blaming and scapegoating. Listen to feelings of guilt and self persecution. Talk about personal relationships with the victim. Interventions continued. So recognize differences in styles of grieving. Assist with development of adaptive coping strategies. Identify resources that provide support. So in the evaluation phase of the nursing process, you want the client to develop and maintain a positive self-concept, learn more effective ways to express feelings to others, to successfully have successful interpersonal relationships, to feel accepted by others, and achieve a sense of belonging.